cavity. As far as anatomy is concerned, it is all repetition, so we are going to repeat it again and again. Acknowledgements, including StatDX, Hans Berger's books, including Diagnostic Imaging Series, handbooks, and of course, Netter's Atlas. So a bit of overview of head and neck. We can divide it into various sections. Some of these we have already covered. First of all is the temporal bone covered. Then base of skull and cranial nerves, we have covered that. Orbits, we have covered that. Today we are going to sinonasal, paranasal sinuses, and the oral cavity. And the last session is going to be the neck, which includes the suprahyoid neck and the infrahyoid neck, in which larynx will be specially covered. This will be next week. Now, we know that neck anatomy over the years has been, in imaging, we use the concept of spaces. And there are spaces in suprahyoid neck and infrahyoid neck. I will introduce you, and I think most of them will be covered in more detail next time. But in suprahyoid neck, these are the 7 spaces. Out of these 7 spaces, some of the spaces continue in the infrahyoid neck. So carotid space, retropharyngeal space, perivertebral space, it is present in infrahyoid as well as suprahyoid neck. Today, we are going to cover a bit of masticator space as well as parotid space, in addition to the oral cavity and paranasal sinuses. So these are the 5 spaces of infrahyoid neck. Again, will be covered next time, but just wanted to highlight that these 3, carotid space, retropharyngeal space, and perivertebral space, also are in the suprahyoid neck. So they are in the suprahyoid neck as well as infrahyoid neck. So some of these spaces, they act as tubes. They go all the way through the neck, and many of them, they actually reach the skull base. And it is very important to remember this concept because tumors as well as infections can transmit through them to the cranial cavity. Out of these, masticator space is one which we will cover today once again, and parotid space, we will revise it. You remember that the masticator space goes to the skull base and it touches the foramen ovale here. The parotid space, of course, this is the stylomastoid foramen through which the facial nerves comes out. The jugular foramen, it is in continuity with the carotid space. We have sort of covered this, but the space in more detail, we will see it next time. So the key concept in head and neck radiology is what is the epicenter of the lesion, which space is involved. Once you decide that, then you see what is the differential diagnosis. And on the basis of the radiological features and the clinical history, you can make a final diagnosis. So I've also told you that the current Chapman, which is the 7th edition, has been revised extensively, particularly the head and neck chapter. It's totally newly written. And this is the differential diagnosis in masticator space. So please remember, masticator space, we have to revise it today because it is next to the other spaces which are our area of interest, and that is why we are going to cover it today and not leave it for the next time. Whenever we do a space, and again repeat that we are going to do them more elaborately next time. There are three things. First, the name, then the extension. What is the extension? And then the contents. So these three things should be known. Now, masticator space, it extends from inferior edge of the mandible to the superior attachment of temporalis muscle. So the temporalis muscle goes and it attaches to the skull, of course. So you can see that masticator space involves all of this region. The contents, the major contents include the muscle of mastication, the lateral pterygoid muscle, the medial pterygoid muscle, the masseter muscle, the temporalis muscle. And of course, there are some nerves. And as far as mandible is concerned, the ramus and the posterior body of mandible. So this is the mandible, and this is the body, and this is the ramus. So all of this will be included, and a few of the molars will be included in the masticator space. So this purple space for you is the masticator space, and you can see that this is the mandible. Surrounding them are the muscles of mastication, and all of this is included in the masticator space. Anterior to that is a space which is the space in your cheek. We call it the buccal space, otherwise it's not very important. You should just understand that this is the fat around the cheek. Posteriorly, there is the parotid gland. So this is the parotid space. So this is now in a craniocaudal dimension. If you see, this is the mandible. This is the purple space, which is the masticator space. You can see it goes all the way here and attaches with the temporalis muscle here. So here it is abutting the base of skull. And this is what we call the mandibular division of the trigeminal nerve, which is the V3, which passes through the foramen ovale. And the same concept that the masticator space goes and touches the base of skull. This is the foramen ovale, this is the foramen spinosum. Once again, this tells you the V3, which passes through the foramen ovale. So on CT scan, and please remember, these kinds of cases are extremely important for the exam. Because of time factor, I might not be able to show you DICOM images today, but I've got a few in my collection which as a practice for your 2B exam, I'll show you. So now look at this, and this should be your protocol. That when you are looking at a CT scan of the brain, you should understand that after looking at the brain, you have to look at the base of skull and anything else in the head and neck. So this is the masticator space. Simple. It's easy to forget. So this is the nasopharyngeal masticator space. And actually, this is the pterygopalatine fossa, which we are going to cover. So people tend to forget that. So this is the temporal bone. Anterior to that is the masticator space. So, and which will be visible, maybe the first space, soft tissues of the neck, which will be visible on a CT head, will be this part. And it is posterior to the maxillary sinus. So next, I'm going down now, and you can see that this is the condyle of the mandible. And you can see that this is the masticator space. This is the medial and the lateral pterygoid plates. And more inferiorly, now the ramus of the mandible is evident. And you can see that this is the masticator space. Posterior to that will be the parotid space. And now we are going further inferiorly. And we can see that now the body of the mandible is coming into view and the alveolar ridge is coming into view. So if there is a tumor in the masticator space, for example, or infection or whatever, it will sort of indent the parapharyngeal space, which is here, and the displacement of the fat of the parapharyngeal space is taken as a landmark. And we are going to learn this skill next time. So this is the differential diagnosis. Once you place anything in the masticator space, of course, there will be many things which you can see here, including infection, including bony lesions, including incidentalomas and motor denervation, tumors, etc., etc. So because of radiological features, etc., you can give a good differential, and many times you can give a single diagnosis. Now, this is a chondrosarcoma of the masticator space. So the first thing is, ask yourself which space is involved. It's a good idea to compare it from the right side when you're not experienced on the other side. So you can see that this is the mandible, and you can see that these are the muscles of mastication. Here, there is a mass which is replacing the muscles. The muscles are not visible. And then it is causing indentation on the maxillary sinus like this. And key point is parapharyngeal space. So parapharyngeal space is one of the key spaces to sort of reach a conclusion of what is happening, which space is the mass or the tumor or whatever. So parapharyngeal space has got fat, which is high in signal intensity on T1 as well as T2 weighted sequence. This is normal. So you can see that the displacement of the fat will tell you which space the mass is. And on this side, there is anterior, something is displacing it posteriorly, telling you that this is in the masticator space. So this is how you use your differential diagnosis skills. This is just a diagram to show that a tumor in the masticator space can go into the intracranial cavity through the V3. We call it perineural spread of tumor. And of course, it will pass through the foramen ovale. This is a case in which there is enhancement and enlargement. I've shown you similar case when we were doing temporal bone, and maybe I'll show you later today once again. So let's go through in a DICOM format. Now, candidate 1, can you see my DICOM viewer?
Yes, I can.
Okay, so now we are going to sort of revise our masticator space. So just concentrate on masticator space and nothing else. Now, if you see here, and I'm going to concentrate on the left side here. So if you see here that this is the mandible, and as we are going superiorly, you can see that this was the anterior portion of body of mandible, and as we are coming to the junction of body with ramus, you can see the alveolar ridge here, inferior alveolar ridge. You can see the teeth here, and on the other hand, you can see this muscle. So this is the masseter muscle, and this is the temporalis muscle. So now means that this is the masticator space. Look posterior to that, and this is the parotid gland. So this is the parotid space. So we are going now superiorly. And as we go superiorly, we can see that there are other muscles the pterygoids, etc., which have appeared from here. If you look very carefully, you might see the pterygoid plates where I'm pointing out. Having said that, this will be better seen on a CT scan for the simple reason that they are bone. However, you can see that these are the muscles, the medial and the lateral pterygoid, temporalis, masseter. So all of this is the masticator space. So let's go down once again and come back. Now, this is it. The mandible is the landmark. Mandible is continuing. And here comes the condyle. So this is the mandibular condyle. And the space comes superiorly. Now look here. The temporal bone is here. The brain is here. And this is what I was showing you on a CT scan, that when you are doing a brain image, please remember that the masticator space will be the first space, first soft tissue visible anteriorly. And if there is something there, don't miss it. Now, if I go superiorly, there is a muscle here. So this muscle has to be the temporalis muscle. So this was the masticator space. Here, we can also cover the parotid space. Now, this is the mandibular condyle. Posterior to that, this thing is the parotid gland. And in the parotid gland, there is a vein here, which is the retromandibular vein. And parotid gland has got two portions. One is this superficial portion. So this is the skin. So the portion which is superficially placed is the superficial portion of the parotid gland. This one is the deep portion. Deep portion is clinically not evident, which makes common sense because a clinician will not see it. So, and similarly, when we report tumors of the parotid gland, we have to tell the clinicians if the deep lobe is involved or not, because the surgical approach or the planning will be different. So within the parotid gland, the facial nerve is there. You might not see it, but you can infer it. Retromandibular vein is there. But as we go superiorly, so this is the parotid gland, and as we go superiorly, now this is the signal void of the mastoid cells. And then this is the condyle, and then we lose it. We are into the brain. So you can imagine that somewhere here, we lose the facial nerve into the signal void of the mastoid cells. And we have done this anatomy on temporal bone in the first session. And posterior to that, of course, this is the external auditory canal, etc. So in conclusion, around the mandible, here is the masticator space, and posteriorly is the parotid space. Right. Now, we go back to where we were. Candidate 1. So can you see my PowerPoint?
Yes, it's PowerPoint now.
Right. So candidate 1, this is your first case. Over to you.
Okay, there are slices of axial CT head. I can see that there is a right anterior right frontal collection, which is hypodense with the surrounding hyperdensity. and it is in keeping with a subdural collection. I can see on bone window that there is right frontal maxillary sinus disease. So the findings are in keeping with subdural empyema due to frontal sinusitis.
Okay, I think you used the word, did you initially use the word maxillary, isn't it? This is
sorry, frontal, right frontal sinus, yes.
Okay. So in this case, and you use the word subdural, and why isn't it extradural or epidural?
It is extradural because I can see that there is kind of buckling of the sulci, and I never thought of that. I would just usually just say that. Yeah, the anatomic description, it would be because it's outside of the parenchyma, it's extraaxial.
Okay, that's fine. Now, this is a classical case for the exam on a brain CT. So these are brain sequences. The patient presented with headache and that kind of a thing. So what we see is that in your exam, you will pick this up. There is an enhancing lesion here. This is an epidural abscess. And once you see this, you will ask for a bone window. And on a bone window, in this particular case, you can see that there are signs of sinusitis, opacification of the right frontal sinus. There might be some bone dehiscence. In this particular case, there was no dehiscence, but it can, even then, there can be an epidural abscess. So this is a classical case, which is for the exam. Now, candidate one, over to you.
Okay, so in this case, there is complete opacification. There is opacification of the right maxillary sinus, and looking, there is a small. I can still see a small area of air. So looking at this image, there is air and also opacification. So this one actually could be due to mucosal retention cyst, because if it was just a fluid inside of the maxillary sinus, I would expect to see kind of a air fluid level.
Excellent.
And
like to do?
Yeah. So I would like, I will inform the clinical team, and this patient needs, will take more clinical history from clinical team and needs to proceed with CT.
Here you are, CT.
Okay. On CT on bone window, I can see that, yes, there is area of opacification with irregular border involving the right maxillary sinus, confirming the findings of the skull X-ray. I would like to have a look at the soft tissue window because I'm thinking that this could be actually an abscess, and in the anterior aspect of the right
tissue window, there was no abscess. Over to you.
There was no abscess. Okay. The other possibility is actually, so if there was no abscess, it would be in keeping with bony proliferation. So the appearance is like ground glass appearance and heterogeneous. So in a, for example, young patient, we think of fibrous dysplasia is the top differential. And so it would be like a...
Which bone is involved?
The maxillary, it's the maxillary sinus, so it's the zygoma. Frontal, I'm just trying to the zygoma, the zygomatic frontal suture is involved here. So it's gonna be...
That's fine, yeah. Well done. Now, this is a case of fibrous dysplasia. Now, fibrous dysplasia, if you see here on this plain X-ray, what has happened is that there is a what we call opacified, opaque right maxillary sinus. But if you look carefully, then it was very well picked up that part of the sinus is still visible. So whatever it is not causing complete obliteration of the sinus. Then on a CT scan, it is clear that actually this is a bony lesion, and this bony lesion is involving the maxillary bone as well as the zygomatic bone. The configuration is ground glass, classical ground glass. So this is fibrous dysplasia. Now, please remember that this is the differential diagnosis in your book, Bony Lesions of Mandible Maxilla Solid. And one of them is fibrous dysplasia. So, if you see here, bony lesions of mandible solid, and then lytic and sclerotic, calcified, ossified, unrelated to teeth is the subheading. Here, unrelated to teeth is the subheading, ground glass mixed or variable. Fibrous dysplasia is extremely important for your exam, and you should have clear-cut concepts about fibrous dysplasia. The summary is written here, so you can revise it from here. But let me tell you that people think that fibrous dysplasia is only ground glass. Do not think like that. Fibrous dysplasia can be ground glass, but it can also be lytic, and it can be mixed, what we call page twide. So basically, when it is lytic, it is more active, and it will show uptake on bone scan and PET scan. When basic pathology is that it is, these are cysts in the bone, and then there is variable degree of ossification, and at a particular time, that ossification might give you a ground glass matrix. Now, the fibrous dysplasia of the face or the face and calvarium can be seen in 25% of monoostotic disease and more than 50% of polyostotic. Maxilla is the most common. And please remember that we have covered it previously in the last session, that to differentiate it with Paget's disease, one discriminator is age. Fibrous dysplasia will be young age group. Second thing is facial bones are more commonly involved in fibrous dysplasia and in Paget's disease, it's the calvarium. And once again, I repeat that please remember that depending if it is active disease, it will show uptake on bone scan and PET scan, and they have shown PET scan as well as bone scan in the exam in other parts of the body. So that doesn't change it. So this is fibrous dysplasia. Okay, now candidate 1. Let me describe this for you. This is an MRI, and this MRI was a brain MRI. And expect that to happen. That the finding is in the paranasal sinuses, but this is a classical brain MR, a flare sequence, coronal T2, axial T2 and axial T2. Now, in the right paranasal sinus, we can see this signal which is replacing the sinus completely. And then we can see something here within the nasal cavity. If you see this and see here, you see this configuration? So something is going from here to here. Can you describe it and give us your conclusion?
Sure. So this is, there is a complete, the right maxillary sinus is completely opacified, and it shows a high T2 signal intensity.
Excuse me, can I stop you there? Opacified is a terminology for CT scan, right? There it becomes opaque. So here it is. Yeah.
So it's a high signal intensity involving the whole of the right maxillary sinus, and it is invading into the right ethmoid sinus, with evidence of cortical breach. And it looks like the epicenter of the lesion is within the maxillary sinus, and from there is extended into the ethmoid sinus. So one of the differentials here, I'm thinking, could this be due to inverted papilloma? But I would like to see if there is any CT for this patient. But actually, inverted papilloma is usually coming from the cerebriform. It has a cerebriform pattern, and it comes from ethmoid coming down. So one thing would be helpful to see if there is any hyperostosis focally. And the other thing, could that be just polyp?
Can I stop you there? Look at the signal. It is completely fluid signal, right? So, so now you don't speak. I'm just going to tell you a few points, and then we will go into a teaching mode of anatomy. Now, the first thing is the signal. It is high signal, just like fluid on a T2 weighted sequence. Usually, a solid tumor will not behave like that. Now, but that's a peripheral discussion. The main discussion is anatomy. Now, if you see here, the lesion is in the maxillary sinus. Here, it does not go into the ethmoid sinus. It is sitting in the nasal cavity. So this is the inferior turbinate, this is the inferior turbinate, and the lesion has gone here. So through which structure will it go here? It must have caused expansion of something, and that is why it has gone here. So we will go now into teaching mode regarding anatomy, and we will come back to this case. So candidate one, this, I will take 15-20 minutes to go through it. You please stay with us, but I'm not, most probably I'm not going to ask you questions. Are you with me?
Sure, yeah.
Now, can you see my PowerPoint nasal cavity and paranasal sinuses?
Yes, I can see that, yeah.
Okay. Now, here, if you see here, there are 6 sinuses, paranasal sinuses, and they are named on the bones from which they arise. So 2 maxillary, 2 ethmoid, 2 frontal, and 2 sphenoid sinuses posteriorly placed. In the center is the nasal cavity. Now, if you see this nasal cavity, there is a septum here, and there are bones projecting into it. Please remember the physiology. Normal physiology is that the sinus, they produce, secretions, mucociliary, and there is a drainage pathway. And all of these sinuses have got a drainage into the nasal cavity. And from there, it goes into the nasopharynx. And we just swallow it. So if the drainage pathway is blocked, then you can get sinusitis. Of course, there is other etiology also. But the main thing here is to learn the anatomy of the drainage pathway. So if you see here, just concentrate on this maxilla. So this is the maxilla, and this is the alveolar ridge of the maxilla. This is the nasal cavity, and you can see that there is a bony septum here. And these are the bones which are visible within the nasal cavity. This is the middle turbinate and the inferior turbinate. So if you see the midline bony anatomy, the septum, which was this bony septum, can be seen here. And 3 bones actually contribute in making this bony component of the nasal septum. Include the ethmoid bone. This is the perpendicular plate of the ethmoid. Then there is the vomer, and then there is the palatine bone. You don't have to worry about these names. You should only know that the nasal septum is partly bony, and this is that part. Here, I will show you in a diagram shortly. There is a cartilaginous part also. So we take it further. Now, if you see here, this is the nose, this is the nasal bone, and there are cartilage here. Of course, this is our nose. Now, if we look inside the nose with a speculum like this, you can see there is a bone projecting inside. This is the inferior turbinate, and then this is the middle turbinate, also known as concha. So I'll use the word turbinate. Now, key point to remember here is vocabulary-wise that this is the middle turbinate, this is the inferior. You can see that inferior is larger. The air space, which is lateral to the middle turbinate, is the middle meatus. This is an extremely important word which you have to remember, middle meatus. Most of the drainage actually happens into this. And here, lateral to the inferior turbinate is the lateral meatus. Now, this diagram has been made by one of our team members, Syed Sabi, who is also creator of our logo actually. When we started this 2 years ago, now he's doing his training in radiology in London. So if you see here, concentrate on this. The main bone here to learn from is the ethmoid bone. Ethmoid bone is extremely, complex bone. And if you see here, this is how the ethmoid bone is. There is a horizontal plate, which is this one. This is the horizontal plate. If I go here, do you see this? This is the horizontal plate, also known as the cribriform plate. So this makes the anterior cranial fossa portion of it. And you remember the olfactory nerves, they pass through it. Now, so this portion is the perpendicular, the horizontal portion or the cribriform plate. This thing is the crista galli, which is this thing. Just a landmark because the dura, it attaches here, and I've shown you on a brain MR, it is beautifully seen, particularly on a sagittal sequence, because there is fat around it. Now, from here is a perpendicular plate of the ethmoid. So this is the perpendicular plate, which is seen here. Now, there is complex structure here and complex structure here. This is the lateral mass, also known as labyrinth, whatever you want to call it. So this is the lateral mass. The ethmoid sinus is sitting within it. So this is the ethmoid sinus. And this is the ethmoid sinus. It is aerated. And key point to remember is that the orbits are right and left. So the bone between the ethmoid sinus and the orbit, this bit where I'm pointing out, is known as lamina papricia. This is a very thin bone and an exam bone because infections of the ethmoid sinus can go into the orbits. And this is a very important concept, which we will come back to this. So now, if you see these names, once again, so this is the cribriform plate. This is the lateral mass. This bone is the lamina papricia, which is touching the orbit. This is the perpendicular plate. And then inferiorly, we can see the vomer, which forms the bony nasal septum. Now, to add to this complexity, there are bones which are projecting from the ethmoid, and these are, one is what we call the superior turbinate, also known as superior concha, but I'm using the word turbinate. This is the middle turbinate, and we are very much interested in the middle turbinate. And there is another bone which is inferior turbinate, but inferior turbinate is not a part of the ethmoid bone. Anatomically speaking, it is actually a different bone. Now, this thing here is a structure which I will come back to shortly. This is the uncinate process. We'll come back to this. Now, this airway here is our area of interest. This is the middle meatus. So this is the maxillary sinus. You can see the maxillary sinus is opening here into the middle meatus. So this is the schematic diagram of a paranasal sinus. Before we take it further, one concept you have to remember is that the ethmoid air cells, we divide them, there are about 3 to 18 air cells. Anatomically speaking, something which is anterior, we call them anterior ethmoid air cells, middle ethmoid air cells, and posterior. And these ones are sphenoid. These are the sphenoid sinus. So this concept is important to remember because the drainage pathway is different. Now, you have to concentrate on these diagrams. And this is the midline sagittal diagram. It passes through the nasal septum. And you can see that this nasal septum is then in continuity with the nasopharynx. Inferior to that is the palate. Now, this is the hard palate where the bone is, and then there is a soft palate. So whatever is passing the secretions of the paranasal sinuses ultimately pass into the nasopharynx, and from there the oropharynx, and we just swallow them. We don't even realize it. Now, this is the bony part. So the mucosa has been removed. And now you can see that the bony nasal septum, the midline, perpendicular plate of the ethmoid, the vomer, and the palatine bone. Here anteriorly is a septal cartilage. Please remember that this septal cartilage is immobile. More anteriorly, the septal cartilage is mobile. And it becomes a very important concept for you to remember because an exam case is where there will be destruction of the septa. And you have to understand that posteriorly, the septa is bony. More anteriorly, it is cartilaginous. So don't overcall it. Now, key thing is the lateral wall of the nasal cavity. So right now, we just learned the nasal septum. Now we are looking at the lateral wall. When we look at the lateral wall, the turbinates, they hide everything. So this is the superior turbinate, which is part of the ethmoid bone. This is the middle turbinate, which is part of the ethmoid bone. This is the inferior turbinate, which is a separate bone anatomically speaking per se. So lateral, hidden from our view here, is the superior meatus. Here, hidden from our view here, will be the middle meatus, laterally speaking, and the inferior meatus here. So what we do is, without mucosa, so this is the superior turbinate, middle turbinate, and the inferior turbinate. Now in this diagram, what has happened is that we have removed the turbinates. And now we are looking at the lateral wall of the nasal bone. And this lateral wall is the key thing to learn. Because on the lateral wall are key landmarks. One of them is this semilunar groove, which is known as hiatus semilunaris. This is a groove. And in this are various openings. Now, the first opening is for the frontal sinus. From the frontal sinus, the secretions go through the nasofrontal duct and ultimately they go into the hiatus semilunaris. and hiatus semillunaris opens into the middle meatus, and then the secretions go like this. Now, other than the frontal sinus, the anterior ethmoid sinus also drain into the hiatus semillunaris, and the maxillary sinus. So this is the opening of the maxillary sinus. It also opens here. Now, there is a very important landmark here, and this is an exam landmark because it is very well seen on a coronal CT scan, and there is importance to it, and it can be asked as an anatomy question in your exam. Here is this, this convexity. This is known as ethmoid bulla. What is ethmoid bulla? Basically, ethmoid bulla is the medial inferior wall of middle ethmoid air cells, and this has got a bulbous type of appearance, convex inferiorly and medially. It projects into the middle meatus. So please remember, on a coronal CT scan, it can be seen beautifully, and I'll show you. Now, through the ethmoid bulla, the middle ethmoid air cells, they also drain into the hiatus semillunaris. So recap, in the hiatus semillunaris, the frontal sinus, the anterior ethmoidal sinus, the middle ethmoidal sinus, as well as the maxillary sinus, all of them, they drain into that, ultimately into the middle meatus, and then drain into the nasopharynx. Now, the posterior ethmoid sinus actually drains into the superior meatus, which is not very well seen on radiology. Now, on the other hand, remember that two sphenoid sinuses are sitting posteriorly. These sphenoid sinuses, they have got an ostium where the probe is here, and they ultimately open into the, we call it the sphenoethmoid recess. So the superior meatus also drains into the sphenoethmoid recess. The sphenoid sinus, it drains into the sphenoethmoid recess, and from there into the nasopharynx. Now, one point is that in the inferior meatus, there is opening of the nasolacrimal duct. And you remember last time I showed you a dacrocystocele of the nasolacrimal duct, and that opens into the inferior meatus. And that is why when we cry, the tears, they come out through the nasal cavity like this. So this is the same recap. This bony portion, this is the lateral wall of the nasal cavity, and the openings are anterior ethmoid air cells, then the frontal sinus, then the maxillary ostium, and of course this is ethmoid bulla, and here the middle ethmoid air cells are also drained. So this is same thing here, repeated. And I want to repeat here is that the posterior ethmoid air cells, they drain into this thing. This is known as sphenoethmoid recess. And the sphenoid sinus also drains into this and into the nasopharynx. So this diagram is exam diagram because this is what is asked anatomy question wise. If I want to ask you something in the exam, part 1 exam, anatomy exam, I'll ask you through this sequence. And this is the coronal. And as an ENT surgeon, they want us to describe this because they want to know what is happening. There is a surgical procedure, we call it FESS, F-E-S-S in capital, functional endoscopic sinus surgery. Basic concept is that they want us to tell them if there is obliteration of the osteomeatal complex, also known as osteomeatal unit. So I will tell you what is an osteomeatal unit or osteomeatal complex. The ENT surgeons want us to tell them the anatomy there. And that is why they will ask you in the exam. And if they want to do surgery, what they do is they actually remove this uncinate process so that the drainage pathway becomes more spacious. Now, the portions of osteometal complex, if you see, this is the maxillary sinus. This is what we call the maxillary ostium. From here till here is the infundibulum. You see this maxillary infundibulum. It opens into the hiatus semilunaris. On a coronal sequence, hiatus semilunaris, you have to stretch your imagination to be able to see it. You don't see it on a coronal sequence, but it's common sense that this is the hiatus semilunaris. And this air space here is the middle meatus. Now, this is the middle turbinate. And this thing here, you see this ethmoid bulla. And this is the ethmoid air cells. And you can see that how it is producing this convexity laterally placed. And there is an ostium here also. So the middle ethmoid air cells will be at this level and they will drain into the middle meatus. And this is the uncinate process. And remember that this is what they remove when they do surgery, uncinectomy, they call it. So this is a CT scan. And if you see here, this is the maxillary sinus. This, where I'm pointing out, is the maxillary ostium. From here to here will be the infundibulum. Then if this is the middle turbinate, so this airway is the middle meatus. And this thing is the ethmoid bulla. So the osteometal complex, the key parts of osteometal complex include the maxillary ostium and infundibulum. It includes the ethmoid bulla, the middle meatus. So this is the middle meatus, the airway, and the middle turbinate, and the uncinate process. So this is the osteometal complex. Now, so I think we take a 5-minute break here. When we come back, I will go through a DICOM of a paranasal sinus, and which will consolidate this anatomy. So 5-minute break now. Candidate 1, are you with us?
Yes, Dr. Khan, I'm here.
Can you see my DICOM viewer?
Yes, it is the DICOM viewer.
Okay. So now we are going to go through anatomy CT of a paranasal sinus, and the best initial plane to evaluate the CT scan of the paranasal sinus is a coronal. So coronal is the best plane. First of all, let's have a global view of the facial bones, and then we will come back to the paranasal sinus. So this is the alveolar ridge of the maxilla, and we can see that, so this is the right maxillary sinus, left maxillary sinus. Of course, it has to be in the maxillary bone. This is the maxillary bone. Now, lateral to that, this is the zygomatic bone. So the zygomatic bone is here, and you can see that this is the orbit. So here is the frontal bone, and there is a suture here, the frontozygomatic suture. Frontozygomatic suture is an exam suture, and they will show you cases of trauma. And there is a concept of Lee-Fort injuries. where this is the lateral wall of the orbit. This is the medial wall of the orbit. So I'll here the frontozygomatic suture. Frontozygomatic suture is an exam suture, and they will show you cases of the lateral wall of the orbit. This is the medial wall of the orbit. So I'll show you a few cases later on, and you have to tell the examiner if the fracture is going through it or the lateral wall is also fractured or not. So this is the frontal bone, and within the frontal bone is the frontal sinus. And now, if I go more posteriorly, then here this is orbit. So medial to the orbit is the ethmoid sinus. So remember, the orbit is still in view, and this is the ethmoid sinus. Orbit, you are going towards the orbital apex, and then you go into the sphenoid sinus. So this is the sphenoid sinus, and you remember your foramen rotundum and the Vidian canal. This is the Vidian canal, and the key point was that Vidian canal is inferior to the sphenoid sinus, and foramen rotundum is lateral to the sphenoid sinus. More posteriorly, we are going into the pituitary fossa, and of course, then the cranial cavity. So with this overview, and another point which is important as far as overview is concerned, that this thing is the pterygoid process of the sphenoid, and we have got a medial and a lateral pterygoid, medial and a lateral pterygoid. And this becomes a exam anatomy, because they will show you cases of trauma. If the pterygoids are fractured, that will fit in with the criteria for Lee-Fort injury. So remember, Leafort injury is Leafort 1, 2, and 3, and I'll show you cases. And in each of them, one of the prerequisite is that the pterygoid has to be fractured, either unilateral or bilateral. So these are the pterygoid plates of the sphenoid. Now, forget about the facial bones and let's concentrate on the paranasal sinuses. So we have gone anteriorly and we are coming from outside the body. So this has to be the nasal bone. And you can see that this is the nasal septum. Now, here is the alveolar ridge of the maxilla. So this is the septum. Part of the septum, as we are going posteriorly, you can see that whole of the septum becomes bony. On the other hand, as I come anteriorly, you can see that the septum is there, but it hasn't got a bone. So this is cartilage. So this is one point to remember. Now if we stop here, this is what we learned as far as osteometal complex was concerned. Now, if you see carefully, this is the nasal septum, and here, this is the middle turbinate, this is the inferior turbinate. So this is the maxillary sinus, and you can see the ostium here. From here to here is the infundibulum. And this lucency here is the middle meatus. On the other hand, you can see orbit here. So this thing, this convex structure here is the ethmoid bulla. And this thing is the uncinate process. This is the uncinate process. This, of course, is the inferior meatus. So as I'm coming anteriorly once again. This time, our aim is to see the frontal sinus. So this is the frontal sinus. And you can see that there is a groove here. And actually, you might be able to see in some cases very well, but somewhere here, and actually you can see it here, where I am pointing out. Do you see this lucency, which is continuously going like this? So this is the nasofrontal duct. And actually it's a recess type of a thing. And from here, the pathway again is into the middle meatus. And you can see it going like this. You see this thing? It is going like this. So, so this was the frontal sinus. Now we will continue posteriorly. Ethmoid sinus is still in view. You can see the orbit there, and then the orbit is finishing, and means you have gone into the sphenoid sinus. So let's sort of marry it with an axial sequence just for orientation. So now I am at the level of orbit, and this is the medial rectus muscle where I'm pointing out. And now you can see how I've gone anteriorly, frontal sinus, and now the ethmoid sinus. So these have to be the anterior ethmoid sinus. Now we are at the middle ethmoid sinus, and key thing is that this is the ethmoid bulla. You can see we are at the middle. We are going posteriorly, and now if you look carefully, we are still in the ethmoid sinus. This is the sphenoid sinus. This is the sphenoid sinus, and now we have gone into the sphenoid. If you look carefully on this axial, actually you can see. Do you see this ostium where I'm pointing out? So this is the drainage pathway of the sphenoid into the sphenoethmoid recess. And generally speaking, if we see it on a sagittal, if we go here and try to orient it, so Actually, you can see it very well on. You see this thing? You see this ostium here, which correlates with this thing. So this is the ostium of the sphenoid sinus. And so from here, the secretions will come here. We are at the midline. But then if we go slightly medially, we can see it will go into the nasopharynx. So once again, on a sagittal, you can see the frontal sinuses here. You can see the, let me marry it with a coronal for orientation. So this is here. Now this is the crista galli. So here you are. This is the crista galli. And you can see this is the sphenoid sinus, the pituitary gland, etc. So whenever you see a CT scan of a paranasal sinuses, you have to describe the nasal septum. Is it deviated or not? You have to describe if the, sometimes there are normal variant where there is aeration of the middle turbinate, maybe slightly, you can see it here. We call it concha bullosa. You have to mention it as a variant. At times, it can cause a bit of obstruction also. You can then you have to describe the osteometal complex, and this is the osteometal complex. Is it clear or not? And then you have to describe all the sinuses. Are they clear or not? And if there is obstruction, then you have to tell where the obstruction is. Then you look at all the bones and see if there is any bony destruction, etc. Finally, all paranasal sinuses CT, please remember, are basically in bone window, right? So you have to ask your radiographers to send a normal soft tissue window also on PACS. And you have to evaluate that also. Otherwise, you are going to miss things. So let's, from here, go to a few Viva questions. So if you see here what is happening, let me go through it. What is happening? This is an antroconal polyp. So polyp, basically there is mucosal thickening, and then this mucosal, because of hypertrophy, what happens is it will pass through the maxillary ostium, and it will sort of enlarge the maxillary ostium. So you can see it is caused expansion of the ostium, and part of it is projecting into the nasal cavity. Look at the signal intensity. It is high on T2 weighted sequence. It is fluid, should I say, in T2 weighted sequence. So this is a antroconal polyp. Now, a few things that role of contrast in sinus diseases is that when there is, on a CT scan, when you see opacification of the sinus, on an MR, it might be due to mucosal thickening, or what we call polypoidal mucosal thickening, or it might be because of two things. One is mucosal thickening, and second thing is fluid. Basically, what has happened is that the ostium is blocked, so there is fluid also. When you give contrast to this patient, sometimes what happens is that the mucosa is compressed and you might not see enhancement. Sometimes you will see enhancement. So this is the mucosa which is enhancing. Central portion is the fluid. Key point to remember, exam point to remember is that look at the enhancement pattern. Enhancement is smooth and thin. It is not nodular, because nodular enhancement means trouble, means there is a tumor sitting there. So this point you have to remember. Now, Candidate 1. This is your last case, and then we will go to candidate 2. Now, are you with me, candidate 1?
Yes, I'm here, Dr. Khan.
Okay, so if you see here, this is a stir sagittal sequence. In head and neck, we do stirs. This is a T1 fat saturated post contrast, T1 fat saturated axial post contrast. You know, the classical protocols which we use in head and neck, we use stir because stir by definition has got fat saturation. We will do T1 without contrast. T1 without contrast is beautiful in head and neck because of fat. We see anatomy very well. And then we do fat saturated T1 followed by post-contrast fat saturated T1. We can also do, or we do T2s also, particularly sagittal T2 to look at the spine, etc. So having said that, let me ask you leading questions on this because of the time factor. If you see here, there is a lot of fluid in the maxillary sinus, right and left, similarly in the ethmoid sinus. When we give contrast, if you see this is the maxillary sinus, there is enhancement, there is enhancement, there is enhancement, there is enhancement. What do you think is happening? Over to you.
Okay, both maxillary sinuses, they show that there is a peripheral enhancement, so it could be in keeping with an inflammatory process or infective like sinusitis. But I can also see that within the ethmoid sinus, more on the right side, there is a heterogeneous signal intensity, which is not like only fluid signal. So I think it's most likely sinusitis in both maxillary sinus